Good afternoon. I'm Congresswoman Lauren Underwood, the Vice Chair of the House Committee on Homeland Security. Welcome to today's virtual forum where we'll be discussing health disparities in the coronavirus pandemic. As a public health nurse and the co-founder and co-chair of the Black Maternal Health Caucus, I am deeply concerned that this pandemic is having a disproportionate impact on the health and well-being of people of color. In my state of Illinois, Black residents who make up less than 15% of the population account for more than a third of cases. And across our state, Latinx majority areas have the highest number of confirmed cases. However, coronavirus disparities are not being tracked comprehensively at a national level. So we do not yet have a full picture of the problem. I'm so glad that we're joined today by two distinguished public health experts, Samantha Artiga and Dr. Michelle Williams, who can help us better understand the disparities experienced throughout our country, share key insights from their research on this topic, and assist the committee as we chart a path forward. But first, I want to thank my colleagues, Congresswoman Sheila Jackson Lee and Congressman Al Green, for joining this important conversation with me. I'll turn it over to Congresswoman Sheila Jackson Lee for her opening remarks now. Congresswoman.
Thank you very much, Madam Chairwoman. It is certainly a privilege to be able to be with you during this very significant moment of health history in our nation. As a senior member of the Homeland Security Committee and the founder and chair of the Coronavirus Bipartisan Task Force, I know that we are not where we need to be. States begin to open in complete opposition to the guidelines established by the federal government of 2 weeks without a sign of coronavirus. We have a lot of work to do. Having supported and advocated strongly for the $25 billion in our last funding, it was specifically to focus on the ability to have testing sites in all of our vulnerable communities, but more importantly, to insist that we are testing in our vulnerable communities and to have contact tracing. We're not there yet. I can assure you that rural parts of Texas that are predominantly Hispanic or African American are not being tested. We are still working very hard to test hotspots or potential hotspots in our urban centers. So the question of disparities is real. The number of deaths reflect that. The work that we have to do as members of the United States Congress is to insist on contact tracing, testing, and ensure that we write legislation, bolster the economic engine of our families so that we can put health and life and physical health over the economic health, and soon both will be standing together. Thank you so very much, and I yield back at this point.
Well, thank you, Congresswoman. Next, I'd like to recognize Congressman Al Green for any opening remarks that he'd like to make. Congressman.
Thank you very much. I'm lowering my mask at this time because I do have a staffer who is assisting me, and we are practicing our spatial distancing as well as wearing our masks when we're in the company of each other. Something I encourage every American to do. This pandemic is not over. Notwithstanding some of the opening up that is taking place, it is still a pandemic that we're dealing with, and it is still deadly. I think that the empirical evidence speaks for itself, Madam Chair, and I'm grateful that you would host this event. The empirical evidence clearly shows that vulnerable communities are overwhelmed. Here's some of the empirical evidence. 40% of the deaths in Michigan involve African Americans. 60% of the deaths in Houston. And in my congressional district, we have a specific area, so we have a high rate of death. 70% of the deaths in Chicago involve African Americans. 70.5% in Louisiana, African Americans. So the testing has already revealed something that we must take note of, that African Americans, I would also add Latinos and Native Americans, are disproportionately impacted. And the question now becomes, what do we do about it? It's one thing to identify a problem, but another thing to take the necessary measures to correct the problem. And there should be corrective action taking place right now in these vulnerable communities, rather than allow this to continue to fester and allow more persons to be put at risk. We should have masks in great abundance in these communities. We should have gloves for them. We should have the necessary sanitizer. And there are other things that I'll mention as well. but the vulnerable communities must receive all of the resources that we can muster at this time. If we do not do this, history will not be kind to us. I thank you and I yield back.
Well, thank you, Congressman Green. I'd like to now welcome our panelists, Dr. Michelle Williams and Ms. Samantha Artiga. Dr. Williams is the Dean of the Harvard T.H. Chan School of Public Health, and she's an internationally renowned epidemiologist. Prior to becoming the Dean, she was a professor and chair of the Department of Epidemiology at Harvard. And Ms. Artiga serves as the Director of Disparities Policy Project at the Kaiser Family Foundation and Associate Director for the Kaiser Family Foundation's program on Medicaid and the uninsured. Thank you both so much for joining us and for giving the committee the benefit of your expertise on disparities. This is a big topic, so let's get started. We're going to go straight to questions. And so I am going to pose the first question, and then we're going to rotate between the other members of our committee, Representative Jackson Lee and Representative Green. And we're going to ask everybody to just ask one question, let the two panelists respond, and then we'll circle through again. Okay, so I'd like to start our discussion by asking both of our panelists to give us some background on today's topic of health disparities in the context of the coronavirus. We're in the middle of a pandemic on a scale that we've not seen in a century. For the first time in history, every single state in the United States is under a major disaster declaration. And as we see over and over again with other types of disasters, this virus is not impacting all communities equally. The diagnosis and fatality rates for people of color are far beyond the national average. And so we'll talk more later about what we know and what we don't know about this pandemic. But first, can you give us a brief overview of the policy choices over the last few decades that have set the stage for this crisis? And then how did we get to a place where a virus that can't see race or ethnicity is inflicting such a disproportionate harm on communities of color? Let's first start with Dean Williams and then go to Ms. Artiga. Thank you. Dean Williams, you're muted.
Hi, good afternoon, and thank you very much for organizing this conversation. Time that we've seen communities of color disproportionately impacted by a crisis. We saw this with Katrina, and we are now seeing this with COVID. I also want to go backwards a whole century to the 1918 Spanish flu. And even in that case, we saw a disproportionate burden of morbidity and mortality during a century ago, largely because of the Jim Crow policies that were put in place. Now, fast forward 100 years, and here we are with COVID-19, and we are still seeing similar disproportionate burden of morbidity and mortality due to COVID-19 in Black and Brown communities. I'm a public health professional, and one of the things about public health is we as a discipline use evidence and science to try to connect the dots to identify risk factors and then bring down, mitigate those risk factors so that the most vulnerable populations are protected and everyone in the process is protected. The policies that are in place that still allow food insecurity, housing insecurity, environmental pollution that is differentially distributed across populations where populations of color have more issues around environmental injustice problems, as well as a lack of communication that is effectively reaching diverse populations, all contribute to a complex set of factors that leave communities of color in harm's way during times of crisis. I can elaborate more on these points, and perhaps I can do so when we address other questions, but I would say that the policies that are necessary for developing a social safety net that provides security in food, housing, education, access to healthcare, access to quality jobs with appropriate measures of protections for workers and flexibility for workers are all a cluster of policies that have to come together to create a system, a web, a social safety net that is resilient during peacetime when we're not in crisis and has surge capacity when we are in crisis. And I'll stop there.
Well, thank you so much. Ms. Artiga.
Great. Thank you so much for inviting me to join and hosting this really important discussion today. I did want to point out that the stark statistics you pointed to in terms of disproportionate impacts you're seeing in some of your districts are really consistent with broader patterns that we're seeing across the country. Really, in the majority of states that are reporting data on cases and deaths by race and ethnicity, we are seeing that Black Americans make up a greater share of cases and deaths relative to their share of the population. We're also beginning to see some really significant impacts for American Indians and Alaska Natives in some areas. And I think growing rates for Latino individuals as well. We'll talk later about some of the data issues that limit our ability to understand how some other smaller populations are being affected. But really, what we're seeing is a very consistent pattern. And I would echo all of Dr. Williams' comments in that pattern really is just exposing what was already a significant set of underlying disparities that have been in place and have been persistent for years. And these are health disparities that are driven by social and economic policies and factors. We know that health is not reflective of just access to healthcare. It is reflective of a broad range of social and economic factors. All the conditions in which we live in which we work in. So thinking about education opportunity, housing opportunity, transportation options, neighborhood safety and amenities, all of these influence health, and people of color continue to face increased challenges in these areas, rooting back to decades-old policies and continuing residential segregation that we see today. I would also point out that there are health impacts of toxic stress and trauma that are long-term physical and mental health impacts that also are more prevalent among communities of color. And even when we talk about when individuals access the healthcare system, there are a set of inequities there that stem from implicit bias, from having lack of access to culturally appropriate or linguistically appropriate care. So all of these issues together are what are driving some of the disparities that we are seeing. And because of that, we really need to take a broad-based, multi-sector approach to thinking about how we address these challenges.
I'd like to recognize okay, then I will go to Congressman Green for a question.
Thank you, Madam Chair. And I do thank the witnesses for appearing with us today. They are eminently qualified and have already acquitted themselves well in terms of according us intelligence that is going to help us to move forward in a very meaningful and positive direction. The question that I have has a lot to do with the systemic discrimination, invidious discrimination. Be quite blunt, quite candid, brutally frank, systemic racism that we still endure in this country. And I'm appreciative that it was addressed very briefly, but I would like to hear more about it. And how do we deal with it as we go forward, such that we don't silo that problem and try to deal with the pandemic without addressing the systemic issues associated with race and ethnicity in this country. So I would ask that of both of the witnesses that we have today in terms of strategies that the federal government can employ to deal with this.
Thank you. Dean Williams.
Yes, thank you, Congressman, for that question. Let me start perhaps with the most fundamental need. And that is we need to have the data. We need to have the evidence to show when there are disproportionate allocation of resources and show the impact of that disproportionate allocation of resources on the health of Black and Brown populations or underserved populations. So data evidence is fundamental for helping to highlight where the problems are and where policies and practices disproportionately disadvantage populations of color. In addition to the data, we also need to have the science, and there is science that documents the toxic biological, physiological, and mental toxicity of racism and discrimination on the health and well-being of individuals. And then when you bring it to aggregate to communities. David Williams, who is a professor of social determinants of health and social and behavioral epidemiology at the Harvard Chan School, has actually developed and validated instruments that are used to measure the physical, biological impact and mental health impacts of discrimination on the health of individuals. Using tested, validated instruments, one can show that racism, discrimination, actually has meaningful physiological impacts that drive a disproportionate increase in risk for hypertension, diabetes, increasing psychosocial stress in ways that become toxic and contribute actually to the high burden of comorbidities that actually make being positive for COVID-19 that much more deadly in populations of color. Discrimination presents itself in other ways, in the quality of hospitals and the accessibility of quality healthcare in communities where there are predominantly Black and Brown populations living. The quality of the care that you receive is going to have some impact. Even though 80 to 90%, 70 to 80% of our health and wellness is determined by social factors outside of the healthcare system, when we need the healthcare system, it has to be of the highest quality that is available to all of us, irrespective of where one lives or what one's income is. And so that is another really tangible way, access to healthcare that is disproportionately available to underrepresented minority people, where discrimination expresses itself in health.
Issue of taking a broad-based view of what the impacts of discrimination are in terms of what we see in health. And again, looking at the community level in terms of understanding that communities with higher shares of people of color have often less educational and employment opportunities, less resources available to help people live as healthy a life as possible in terms of opportunities to engage in behaviors that allow them to be healthy. The other issue that I would just raise is it's important to recognize the role that discrimination plays in all this, and to recognize that different groups feel discrimination differently and have different experiences with discrimination and different histories in terms of their relationship with the government. Thinking in particular about American Indians and Alaska Natives and the long history there, the unique roles that the federal government has for that population, but also thinking about Asian Americans and Latino Americans who have high shares of immigrants in their populations, who have really been experiencing a lot of stress, anxiety, and uncertainty as a result of recent immigration policies. That are contributing to the types of toxic stress and trauma that Dr. Williams referenced, which will also have long-term impacts for their health and the health of their children.
Thank you so much, Ms. Artiga. I want to see if we can get Congresswoman Jackson Lee into for the conversation for a round of questions. Congresswoman.
Thank you so very much. Let me, first of all, again, thank you to Chairwoman Underwood really for the work that she's done to focus on public health. I enjoyed the opportunity to collaborate with her on Homeland Security. And as well, let me indicate to both Dr. Williams, Dr. Artiga, I think your work now is probably more crucial than any we've seen or any time in our history. I have a pen op-ed that says that what we're in now is a national security crisis as well as a health crisis in terms of the potential impact in communities that heretofore not had access to health care, have suffered from disparities in access, but also with underlying conditions. And there may be additional research that indicates there's more to this question, having such a high number of Latino and African Americans engaged, impacted rather by COVID-19. I've worked in setting up at least 7 testing sites here in the Houston Paris area, and we have tested the dominance of African American and Latinos, and the numbers are between 8-9%. I believe it's increasing in positive. We also work to test, and that was a very high rate of positive, and those populations also were minority populations. So my question, and to put on the record again, this particular state, as an example, has begun to open up by way of the orders of the cases of positive COVID-19. We see that in many other states. So my question to both of you is the question that if we are not testing hotspots or tests in areas both rural and urban of minority populations, can this not lead to a health crisis, impact national security with increasing numbers of fatalities? And what should be the federal government's, again, the federal government's level of involvement, engagement, anxiety, but anxiety does not bring about solutions. So what should be the level of attention, heightened attention, planning, and efforts? What level should that be at the federal government by taking note of the disparity, not only in poverty, death?
Thank you, Congresswoman.
And that would go
Definitely.
to both Dr. Williams, Dr. D.
Okay, great. Dr. Williams. Dr. Williams, if you would unmute yourself.
Thank you. It's a very important framing of the question and the question. And I will say that a lot of the anxiety and a lot of the concern could be mitigated if we and when we get to the level of adequate testing capacity. We are months into this pandemic and we are still not at that level. And it's the availability and access to testing was actually delayed and is still delayed for reaching the most vulnerable populations. Underrepresented minorities and low income individuals who are in the gig economy or in lower paying jobs are less likely to have the opportunity to work remotely. And that has put them in a great deal of jeopardy in trying to choose between how to remain gainfully employed, to work, and to remain healthy. And the lack of availability of testing has just accentuated that problem. There are communities that it was only 4, 5, 6 weeks into the explosion of this epidemic in different regions of the country that testing sites were set up in communities of color. The uncertainty and the lack of availability essentially drove a lot of the spread underground without evidence and data for communities that COVID-19 was in some way not a problem in these communities. And that was largely due to misinformation, but also mismessaging, that the message and the messenger did not reach a diverse population. It took too long for us to have Spanish language messaging about the importance of social distancing, physical distancing. It took too long for us to set up testing sites in communities that were not being served. And it was only when we started to do the testing that we saw in those states and those communities where ethnic and race-specific information were being reported, we could see this disparities. So it comes back to having all sectors and segments of our communities.
Thank you, Dr.
Thank you, Dr.
Ms. Artiga.
Ms. Artiga.
Yes, so, I'm sorry, I'm getting feedback. Are you hearing that? People of color are more likely to be in low-wage jobs and in service industries, which, as Dr. Williams points out, puts them in this really tough situation. They have really limited resources to not work because they don't have a lot of savings or resources to fall back on. And they don't have the types of jobs that can be done at home. So that forces many to have to continue to go out into the community to work in order to protect themselves financially, but then putting them at risk and their families at risk for exposure to the virus. So I think really in thinking about how we address these needs, it has to be both on the financial end as well as on the health end in terms of protecting the individuals financially if they're exposed or unable to work, but also thinking about for those who are continuing to work, what sets of policies and procedures can be put in place to minimize risks. I would echo the points about data. Not only is it important for us to have data in terms of how different communities are being affected, but also data to understand the extent to which different communities are able to access different resources and types of relief that are being provided, to understand if those resources are actually going to where the need is. I would also emphasize this issue on communications in that there has to be effective, appropriate communications developed for the communities that you're trying to reach. And that really has to be done through trusted individuals and trusted organizations among those communities. So thinking about how you can build relationships with and draw on the expertise and relationships that exist within the community among community-based organizations that are already serving individuals there. Also thinking about the roles of ethnic media and other types of information sources that are important for different populations. And that's going to vary across groups. So there's not a one-size-fits-all approach. We talked some about the need for Spanish language translation. There are also a lot of language needs that need to be addressed for Asian populations, often in multiple languages. So thinking again about the varied needs of the different communities that you're trying to reach and help.
Well, thank you. I want to move over to data collection. We know it's hard to solve a problem that you can't measure. The data that we have so far reveals significant racial and ethnic disparities in the impacts of the disease. On Tuesday, AMFAR, the Foundation for AIDS Research, released preliminary findings that counties with higher Black populations, which account for 22% of US counties, had 52% of the country's COVID-19 diagnoses and 58% of deaths. In my state, our governor recently reported that among all Illinoisans who've taken a coronavirus test and checked the box for Hispanic, 60% tested positive for COVID-19. That positivity rate is nearly 3 times the state's average. However, we don't have a complete picture of the data in Illinois or nationally. In Illinois, 52% of tested residents left the race and ethnicity box blank. Nationally, as of May 3rd, 55% of COVID case reports submitted to the Centers for Disease Control and Prevention had the patient's race missing or unspecified, and almost 60% had ethnicity missing or unspecified, according to the Trust for America's Health. So, Ms. Artiga, can you speak to likely causes and potential consequences of these gaps? And what can the federal government do to make sure that comprehensive, disaggregated demographic data are being collected and reported to public health departments and the CDC?
Thanks. So, I mean, we keep coming back to this issue that data is really an essential piece of these health equity efforts. And as you said, it really comes down to if you don't measure it, you can't improve it. We need data to identify the disparities and understand the factors that are driving them. We also need the data to help develop and target interventions to address those disparities, as well as looking forward to think about how we measure any progress in terms of and the impact of any policy changes or interventions that are put into place. We have made some strides forward in data collection. In particular, the Affordable Care Act established a set of data collection standards that was meant to create consistent data collection categories that would provide for disaggregated data and consistency across reported data. But there are still significant data gaps. As you mentioned, data on race and ethnicity is not always complete. We often still really only have small sample sizes for smaller population groups like American Indian and Alaska Native people, as well as Native Hawaiian and other Pacific Islander individuals. And that really limits our ability to do any analysis specific to those populations, as well as for subgroups of populations like subgroups of Asian individuals. I think continuing to promote and to some extent potentially require data collection consistent with the standards that were put forth would help improve the consistency of the data. We've seen over the past few weeks a lot of progress forward. Now nearly all states are reporting cases and deaths by race and ethnicity, but there's a lot of inconsistency in how states are reporting those data. I think also thinking about if there are targeted ways or resources that can be directed to getting more information from these smaller population groups where we typically are lacking enough data to fully understand how they're being affected. And also to improve the completeness of the data. Typically that racial and ethnic question is an optional question. So thinking about providing some outreach and education about why responding to that question is important and helpful to the person who's actually providing that response. I think typically we don't see any information on those forms or have any information about why it might be beneficial to me to provide that information on the form. So I think thinking about how usually there are some data sets where the data is based on observations, which is really prone to error. So thinking again about that data collection strategy is going to be key.
Thank you. Mr. Green. Do you have a second question?
Yes, thank you. As I indicated, I'm being assisted and we're maintaining our spatial separation. I appreciate all that has been said and concur with what has been said. And I'm of the opinion that we do need to continue the testing. But I do want to ask a question related to the empirical evidence that we have currently. And it seems to me that the death rate is empirical evidence that cannot be ignored. I went over these numbers previously, but sometimes things bear repeating for emphasis. So let me repeat. 40% of the deaths in Michigan, African American. 60% of the deaths in Houston, African American. 70% in Chicago, African American. 70.5% in Louisiana involve African Americans. This information, this empirical evidence alone seems to be enough for us to conclude that we've got to marshal a huge amount of resources into these communities. And I'd like to now talk about this in a more mundane fashion. Some of the things that are not that difficult to do that are not being done. It would seem to me, knowing what we know, desiring to know more, but knowing what we know, we ought to have masks readily available to every person in a vulnerable community. We ought to flood these communities with masks. Knowing what we know, it seems to me that we ought to have the gloves and we ought to have all of the hand sanitizer. We ought to make these communities a priority for resources. Seems to me, knowing what we know, we ought to do something about the housing issue. I sit on financial services. The housing subcommittee is a part of the financial services full committee. We know that in vulnerable communities, people don't have in their homes, always have, the necessary spatial separation. And if we know this, and we know that we're having this epidemic to manifest itself in a large way in these communities, it seems to me that we should be making some kind of plans to allow people who are the victims of this virus or who need to separate themselves, quarantine themselves, some space. The government has to take care of people. These people are taxpayers. They're patriotic Americans. They've done what was requested. They'll go to work in some cases and go to work in other cases and be exposed to the virus. So tell me, if you would, please, both witnesses, tell me about some of these mundane, the commonplace things that can be done based upon the empirical evidence that we have now, so that we can protect the people who don't have the virus in these communities, and also help those who do have it to isolate themselves appropriately so that it is not spread to other people within these vulnerable communities. I would ask that both witnesses respond. And again, Madam Chair, thank you again for a wonderful job you're doing.
Thank you. Dr. Williams?
Thank you, Congressman, for that expansive question, which challenges us to think pragmatically. First and foremost, in this acute moment of the pandemic, we have to think strategically and act appropriately. And that does mean providing adequate personal protective equipment and testing, so that we can address the issues that are around the uncertainty of where the hot spots are, where they're going to be, and provide the protective equipment so people can navigate the decision for reopening the community and re-engaging with the work, the things that we have to continue to do that we have failed to be completely successful in doing. And that is, we can't have public health and health equality if there are still disparities in basic fundamental resources like secure housing. Housing insecurity and food insecurity undergird many of the problems that we see in the disproportionate burden of infectious diseases like COVID-19 and non-communicable chronic diseases like heart hypertension, diabetes, chronic lung disease in our communities. So the pragmatic thing that we have to do now in the time of the pandemic, and even when we make it out of this pandemic, is to be sure that we are addressing the basic fundamental social, environmental, and behavioral determinants that impact the health and wellness of our populations. And that really means having a well put together, sustained safety net that includes the provisions and the support for safe housing, a clean environment. I mean, when COVID-19 started to break out and we were telling people to wash their hands, and people in Flint, Michigan still have problems with access to clean water because of the lead crisis there. These are, insecurities in the basic needs to sustain health and wellness, access to clean water, that affect some of our communities. So we have to think systemically. We have to think about the environment, the economic environment, the social and physical environment, and we have to think about the complete environment, not just siloed programs or categorical programs. Take a systemic approach, and we can get to a place where we reduce the risks of underlying comorbidities in our population and have the surge capacity when crises like Katrina or an infectious disease pandemic like COVID-19 hits our community and our environment.
Thank you, Dr. Williams. Ms. Artiga?
Yeah, the only other point I would just add into this mix is also the continuing disparities in health insurance coverage rates. and that people of color remain much more likely to be uninsured, which has real impacts on access to care and use of care, which drives some of the underlying health disparities that we're seeing that are leading to the higher rates of illness and death among these populations, but also is creating a barrier and concerns about the ability to access testing and treatment services for COVID-19.
Thank you. Congresswoman Jackson Lee, did you have a final question?
I do. Thank you. Yes, I do.
Okay.
Thank you so very much. Again, thank you for leading us in this very important discussion. And as my colleague, Congressman Green, I had a mask on earlier. I want to thank him for reminding us of the necessity of doing just the basics that help to save lives. And thank him for that, and enjoy collaborating on these many important issues. I'd like to frame my question again around national security, but also preparedness. I've been utilizing in the community and as I speak, don't panic, prepare. Don't panic, prepare, or prepare, don't panic. And that's my concern about where we are and with the number of deaths that we had. As indicated, Texas is one of the states that has ignored local and county and city stay-at-home orders and began to open up the state again. Really, I think the economy over lives. And the day that Texas was issuing its order, April 30th, we had 1,033 new cases of COVID-19. And as I've indicated, we've steadily increased. In our jail, we had 601 positive cases, 601 positive cases in the Harris County Jail. And to their credit, they are increasing the testing because there are certain elements of the science that we're hearing that we're not really finished with COVID. And we say this not to scare people, but to give people plans such as testing, containment, self-isolation, and ending community spread. So to both doctors, I'd appreciate your assessment of what happens if the nation is not prepared for, say, a fall surge of COVID and the flu on vulnerable populations. What happens to jail populations that are not tested, or the Federal Bureau of Prison that are not tested? In our local jail, we've had two souls, sadly, have lost their life, an inmate and a worker. What happens to the frontliners, essential workers, but those who are in the hospitals? I've heard stories of exhaustion. And I know that when we think of training new persons, shouldn't that be a form of preparedness? So that schools like Pee Wee and Allstate and Texas Health, who trains vocational nurses, should all of these colleges and other schools be up and ready to prepare the next line of workers if we have this? So to both doctors, is this question, is the federal government, in your opinion, dealing with these disparities, this loss of life in a way that they are preparing so that we don't panic and so that we can save lives, and particularly the vulnerable communities that we've been talking about, African Americans, Latinos, that are at the highest number of loss of life?
Thank you for that question. And as Dr. Williams and Ms. Artiga prepare to respond, I'd like to also invite them to fully respond to Ms. Jackson Lee, obviously, but issue any closing comments in their response. So first to Dr. Williams, thank you.
Thank you. Thank you for this challenging question, and it's a really important one. And I will say, for all too long, we have gone through a cycle of panic and complacency. We have now seen, for everyone to bear witness, that we were woefully unprepared for this pandemic, even though the signs and the warnings had been out there. I want to say that how you frame the question is critically important. We've also, in this particular example, seen that by our lack of preparedness, we have essentially experienced a breakdown of our financial security as a nation and perhaps globally. And we have seen threats to our national security. And we have seen this by other challenges of nature, such as natural disasters, storms that have wiped out communities, climate change, which is now recognized as a threat to national security and maybe even the global economy. So I would say that what we have to do going forward, take these lessons learned and build and be prepared in a proactive way to secure the health and wellness of our population, physical and mental health of our population, recognizing that we have a valuable workforce of first responders. Frontline healthcare workers are the foot soldiers, the VIP for preparing, supporting public health. And in supporting public health, we support national security and fiscal and economic security. So the investment in the human capital at all levels, across all communities, is fundamental to being prepared and building a resilient and sustainable environment for feeding and supporting national and global security. This is not rocket science. I think it's essentially understanding that we are all in this together. If there is an outbreak in one place, it's an outbreak everywhere. And we're living this now, and we can be prepared with the proper leadership, with the proper position of resources, the implementation of policy that supports public health, global health, social justice.
Thank you so much, Dr. Williams. And Ms. Artiga.
What we need in terms of the response to this pandemic and for thinking about how we better prepare ourselves for the future is really the importance of thinking about understanding the unique needs of different individuals and different populations, in particular those who have higher needs or face more challenges. You referenced some of the issues affecting individuals incarcerated in jails and prisons. Also need to think about, for example, issues impacting individuals who are experiencing homelessness. We've talked a lot about the different ways in which we can better understand and develop targeted responses and communications to reach different groups of individuals most effectively and appropriately. I think we've also really discussed the broad nature of factors that are driving a lot of what we're seeing and the need for a really broad cross-sector approach. I also think that it's helpful to look where there are existing policies in place that can be pushed forward to help reduce disparities that we know exist. Again, coming back to the issue of health insurance, we still have 14 states that have not implemented the Medicaid expansion, and that's contributing to, in particular, the disparities we're seeing in health coverage for Black Americans, because they are more likely to live in the South, where a number of states have not expanded. As such, they're much more likely to fall into a coverage gap because of the state's lack of expansion of Medicaid. I also would just want to end with thinking forward, the importance of really using this unique opportunity that's been presented to us. I don't think I've ever recalled a time when there has been such a heightened awareness and understanding of disparities and why they really matter. And so using this as an opportunity to build in equity as a priority and goal for a broad range of policies going forward, not just on the health side, because we see that the health is driven by these other sectors. So how do we build in advancing equity as a priority and a goal across sectors, and also as a measure of success when we're thinking about evaluating the impact of different policies and approaches moving forward?
Thank you, Ms. Artiga. I understand that Congressman Green had a brief closing comment he wanted to offer.
I do. Yes, I do, and I thank you. I think that when we changed the order, I assumed that we would have me give a comment as well. But thank you. And my closing comment is simply this. In every crisis, the leadership makes a difference. The leadership can set a standard by which others will immediately assume they should follow. And my hope is that as we go forward, that the leadership at the very highest office in the land will take this much more seriously. And in so doing, will measure thoughts and words, because people have been harmed by some of the statements coming from the highest office in the land. And that leadership, in my opinion, has not been at its zenith. My hope is that we'll get the kind of leadership that we need as we go forward. Thank you.
Thank you, Mr. Green. Thank you so much to all of our panelists, Ms. Samantha Artiga from the Kaiser Family Foundation and Dr. Michelle Williams of the Harvard Chan School of Public Health at Harvard University. As this pandemic progresses, it's exposing and exacerbating the inequities in this country, in particular in our health. The federal government must do more to create the conditions that allow all Americans to be healthy and improve health outcomes in marginalized communities, especially during this crisis. The committee is so grateful for your willingness to share your expertise with us today as we continue our work on this urgent issue. Thank you again to Congresswoman Sheila Jackson Lee and Congressman Green for leading this conversation with me today. Finally, I want to thank Chairman Benny Thompson for his continued leadership of this committee's important work. That concludes today's forum on health disparities. Thank you all so much and be well.
Thank you.